Good afternoon, everyone, and welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speakers for today, I have a few housekeeping items. This CME activity is jointly provided by the Queen's Medical Center and UH-JABSOM Department of Geriatric Medicine. As a reminder, evaluations are required for CMEs. You can find evaluations by following the link in the chat at the end of this presentation or on our email advertisement or on our website. Your comments are very important to the planning committee and will be used to plan future programs. So please do give us your comments. Today's speakers have declared no conflicts of interest with financial entities. It's my great pleasure to introduce our speakers for today. This is my favorite Grand Rounds. Every year in June, the last Grand Rounds of the academic year, we have our fellows present their academic projects. This year, we will have 4 projects. 2 are research projects and 2 are quality improvement projects. I'm going to introduce all our speakers, and then we will have all 4 presentations and then take questions at the very end. Our first speaker is Dr. Pedro Aguilar. He's a second-year fellow. He's originally from Guatemala. He completed his residency in family medicine at CMAR Marysville in Washington State. He loves to work with kupuna and their families and help them navigate their health journeys. After graduation, he's returning to Guatemala to work on outpatient primary care and geriatrics. Our second fellow is Dr. Kaimana Kale. He's originally from Hilo, Hawaii, and completed family medicine residency training at the University of Hawaii. He loves spending time with kupuna, listening to stories, and managing the complexity of elder care. After graduation, he's returning to Hilo to work in nursing home and outpatient geriatrics. Our third fellow is Dr. Stephanie Liu. She's originally from Orange County, California. She completed residency in internal medicine in Phoenix, Arizona. She loves how rewarding it is to help guide patients and their families through this stage of their life. After graduation, she will be working in home-based primary care with the UCSD doing transitional care. The next fellow is Dr. Daniela Orias. She is originally from Honolulu, Hawaii, and attended Moanalua High School. She then completed residency in family medicine at the University of Hawaii. When asked why she loves geriatrics, she said she loves the people. She loves the people when practicing geriatrics. Next year, she will be staying on as a second-year fellow. We're very glad to have her back. Our next fellow is Dr. Maxwell Shen. He was born in Shanghai, China, and then grew up in various parts of the United States. He completed residency training in internal medicine at Tripla Army Medical Center. He loves being able to help elderly patients during their critical moments in life, navigating the family dynamics and offering support. After graduation, he will be working as a hospitalist at Kokini Medical Center. And last but not least is Dr. Aarti Sridhar. She is originally from India. She completed residency training in internal medicine at Mercy Catholic Medical Center in Philadelphia. She enjoys learning from the elderly as they have so many wholesome stories and experiences. She finds it very satisfying to be able to help patients at this vulnerable period in their life. After graduation, she will be a hospitalist at Tidal Health in Salisbury, Maryland. Please join me in welcoming our fellows, and I'm going to hand it over to, I think, Stephanie and Daniela for the first presentation. Again, please hold your questions until the end. We will be taking all the questions after all 4 presentations are completed. Steph and Daniela, on to you.
Thank you, Dr. Masaki.
Thank you, Dr. Masaki. Hi, everyone. I'm Daniela. And we have Stephanie here as well. Just going to share our slides. Okay, is it showing to everybody? Let me just share it.
Yes.
Okay, is it in presenter mode?
Yes.
Great. Okay. So thank you all for being here. So the first project that we're presenting is called the Body Roundness Index and All-Cause Mortality in Older Japanese American Men, the Kuokini Honolulu Heart Program. Myself, Dr. Liu, and Dr. Sridhar thought about this project and wanted to learn a little bit more about it. And so with the help of many of our faculty, we were able to analyze it and come with our results today. So before going into the project itself, just wanted to mention we are affiliated with the Department of Geriatric Medicine at JABSOM, as well as Kuakini. And as far as disclosures, the Honolulu Heart Program portion, which we took the data from, was funded by NIH and also associated with Kuakini Medical Center. So first, just wanted to put out some food for thought. Like how do we define obesity currently in our medical practice? When probably the first thing that comes to your mind is the body mass index and the BMI and our cutoffs for obesity. But as we know, BMI has its own flaws. It basically just takes into account your height and weight, but doesn't really take into account how that weight is distributed across the various tissues in the body or even where in the body. Then I wanted us to think about why is it important? What are the health risks of obesity and why do we care about this topic? And that's because obesity really affects pretty much every health system, every organ system to some extent, and can cause a lot of down the line negative health events with chronic disease. And then lastly, does our current definition of obesity correlate well with predicting the risks of obesity? Maybe sometimes for some, but not for everybody. Like, for example, people who have higher body mass of muscle, they will have a very high BMI, but that doesn't necessarily mean that they're at that same health risks as someone who has the same weight, but their body mass is composed of adipose tissue. So we wanted to learn more about the body roundness index, which hopefully is a way that we can get a better idea of the risks associated with higher weight associated with abdominal circumference, which is a better predictor of outcomes that are associated with obesity. So basically, it's this really complicated formula, maybe not as user-friendly as the BMI, which is pretty straightforward, but you really only need two data points still, the waist circumference and the height, and then you plug it into this equation. It was developed a lot more recently, so I believe the body mass index was created back in actually, that says 1990s, but I think it was developed before that, based off of a group of mainly males, Caucasian males. And so one, not really applicable to our diverse population, but also it's pretty old. The Body Roundness Index was created a little bit over a decade ago by a mathematician. And so the reason why it was created was to try to better account for the distribution of fat, which is why it takes the waist circumference specifically. And as we know, visceral adiposity is more associated with things like cardiovascular diseases and risks. And so that in a way is a way around trying to account more so for the visceral fat rather than things like muscle mass and skeletal mass. The ranges are different compared to BMI. It's smaller number from 1 through 16, but basically the higher the number, that would indicate the rounder the body type is. Currently, there's been a lot of research done on the body roundness index in the past couple of years alone. A lot of the studies are done on big groups out of China and the US. And what they're showing is a U-shaped association with BRI and all-cause mortality, essentially showing that really low BRI and really high BRI is associated more so with mortality. And the only issue is that a lot of these studies are done on, you know, generally younger population compared to our demographics of geriatric patients. So our goal for this project was to explore the applicability of the BRI specifically to a population of lean Japanese American men of older age. So as far as the study design and the population, as we know, we started with data from the Kuakini Honolulu Heart Program. Probably a lot of us are very familiar with it, but it's was part of a branch of a really amazing larger study, the Nihon-san study, which was looking at people from Japan, Honolulu, and San Diego, I believe. One of the San, and then
San Francisco.
San Francisco.
My apologies. I always get the two mixed up. But established back in 1965, taking information from Japanese American men who were born from the 1900 to 1919. And then we used the data for our study starting from examination 4, which was around 1991 to 1993. And this was comprised of an original set of 3,741 men, which the actual amount of people who we were able to get the data from was still a really high number, but 3,605. And these were people who were aged 71 to 93, so a much older age bracket than typically looked at the previous studies I mentioned. And then next, Dr. Liu will explain to us a little bit more about the outcomes.
Thank you for handing it over, Daniela. Hi, my name is Stephanie. I'm the other geriatric fellow that is partnering with Daniela on this presentation. In terms of methods, we're first going to talk about the variables that we kind of used as our predictors. Our predictor value variable would be actually the BRI, which is the calculation. So we used the exam 4, which is I forgot what years it was, but we used the waist circumference and the height from exam 4 from all of the members of the study, and then we actually took the BRI calculations and split it up into 4. So basically, based on their BRI, the value, we separated it into 4 quartiles. Our outcome variable is all-cause mortality. So it's how did the patients pass away, or the time it took for the patients to pass away. So the mortality data was available through December 2023, which is pretty remarkable for those 3,000 people. So we had up to 33 years of follow-up for this. We did take into account covariables. Our covariables are baseline age, cardiovascular risk factors, such as heart disease, stroke, as well as cancer and COPD. Next slide, please. Oh, back one. There we go. Okay, so for statistical analysis, we use kind of 3 total statistical models. We calculated age-adjusted mortality rates per 1,000 person years during follow-up, and this was split up by quartiles. We have some graphs in the next couple slides. The second method of analysis we used was Kaplan-Meier curves, and then this we used to kind of calculate the survival probability based on those quartiles. And then the third thing we used was to calculate for covariability. We used the multivariate Cox regression models to do this. We did this based on the BRI quartiles, and the quartile 1 was used as our reference point, and I'll let you know why. Next slide. So this is our age-adjusted mortality rates. So as you can see, so when we look at quartile 1, 2, 3, and 4, 4 would be the highest BRI, 1 would be the lowest BRI. So if you look at quartile 1, you see that this has the highest age-adjusted mortality rate. Basically, to translate, it means that the skinnier and lower BRI the patient had, the higher their mortality risk was, which was actually an interesting calculation that we came to. Next slide. The next set of data points is the Kaplan-Meier survival curves. Again, I don't know if we're able to zoom in, but if you see the blue line is quartile 1. So this is actually that lowest BRI. And if you can see, it's kind of separated from quartile 2, 3, and 4, just kind of confirming that in terms of survival probability, the lowest BRI quartile has a lower survival probability. And our p value was less than 0.5, so it's statistically significant. And then, so the last piece of data we have is just our Cox regression curves calculating for covariability. All of these were compared to quartile 1, which was the lowest BRI. And if you can see, they're all statistically significant when we're adjusting for all those risk factors. Okay, next slide. So in terms of discussion, I wanted to talk about limitations and strengths of the study. So one of the limitations we have is BRI is such a new way of measuring kind of visceral body fat and abdominal circumference. So there's no real strict cutoffs defined for BRI in the geriatric population and just as a whole. There's some note. I think there's a slide at the end that shows some notes about like what they based on other studies, they've kind of said like, okay, this is the range for quartile 1, 2, 3, and 4, and that's what we used. There's also limited generalizability to this because BRI really can vary between like different racial and ethnic groups. We use primarily Japanese American men, so of course there's going to be tons of data. There will be tons of data on different populations. And surprisingly, a lot of the BRI, like when we did our lit review, a lot of the BRI studies were based on Asian men too. So I think it would be very interesting to see what other kind of ethnic groups in terms of BRI shows about their mortality as well. Yeah, so visceral adiposity deposits have been reported to be higher in Hispanics, followed by non-Hispanic Blacks and non-Hispanic whites based on other studies. The strengths of our study is, we had a really large sample size, 3,000 people that we were able to follow. So I thought that was really impressive. We did focus on a pretty underrepresented group, Japanese American males. And especially geriatrics. A lot of when we did our lit review, a lot of these studies were on patients from the age of like 40 to 70. So we kind of hit the minority there. We had a really long follow-up period of 33 years from exam 4. And this applies BRI to the geriatric population, and there was very little loss to follow-up. So I thought that was great. Next slide. So in conclusion, I think what we came to kind of conclude was that BRI can be a very promising tool for studying cardiovascular and mortality risk. It is super interesting that the lowest quartile shows the highest mortality. And when we were thinking about it, this might account for like frailty, especially in our Asian American population as well. And in geriatrics, frailty is such a huge risk factor. So that might be one of the things that we have to take into account. The only problem is the cutoffs for geriatrics are not very well defined. But yeah, in conclusion, low BRI is associated with a greater all-cause mortality. Higher BRI suggests actually a protective association in terms of mortality when we compared it with our covariables like cardiovascular risk. So in the future, it'd be really interesting to study interactions with CVD risk factors, other CVD risk factors, as well as other subgroups. And especially stratifying this based on age is really important because I think when we look at the other data from younger populations, the BRI is not as protective as we thought when it's lower. So, or not protective when it's lower. Yep, thank you. And we'll save questions for the end after the other 3 presentations.
Thank you.
Yep, and I'll pass it on to Arthi and Max next.
Thank you, Stephanie and Daniela. Let me just share my screen. All right. Okay. Is everyone able to see my screen?
Yes.
Okay. All right. Well, good afternoon, everybody. Thank you for being here. Today, Max and I will be talking about exploring the link between midlife physical activity and the incidence of Parkinson's disease in Japanese American men. And this is, of course, based off the Kuwakini Honolulu Heart Program. And I'd like to just thank my co-authors, Maxwell Shen, Dr. Misaki, Dr. Petrovich, and Dr. Ross. Affiliations being the Department of Geriatric Medicine, University of Hawaii, Kuakini Medical Center, the Pacific Health Research and Education Institute. And the funding disclosures, we have National Institute of Health and Kuakini Medical Center. All right, so just a little bit of a background. So Parkinson's disease is now, one of the second most common neurodegenerative disorders. And unfortunately, very little is known about the risk factors. And the prevalence of this disease has doubled in the last 25 years globally. And as of 2019, there were nearly 8.5 million people living with Parkinson's disease. And we've always seen that there is a very close link between physical activity and cognitive, changes in the brain. So we wanted to look at what effect the physical activity had on the development of Parkinson's disease. And doing a literature review, we saw that there were a lot of mixed results. And so we decided to look into this further, and we studied the association of midlife physical activity in Japanese American men, and we followed up the cases and looked for the risk of future development of the disease. And so our methods, it was involving the Kuakini Honolulu Heart Program, which is, as we all know, a population-based prospective cohort study, which is amongst 8,006 Japanese American men living on the island of Oahu, and it began in 1965. So we predominantly looked at the examination between 1965 to 1968. And we focused on men between the ages of 45 to 68 years. And we started with finding out an estimate of their 24-hour habitual physical activity index. And how we did that was we used a questionnaire which specified the number of hours spent on 5 different activity levels, which included no activity, sedentary, slight exercise, moderate, and heavy over a typical 24-hour period. And that was multiplied by a weighting factor, which was given to each activity category based on, and it kind of brings into account the estimated oxygen requirement or the oxygen uptake for each class of activity. And they were multiplied, and that's how we got this value of the PAI. Using the PAI, we had that data, and we continued to follow these patients. And the follow-up period began 12 years after the baseline, and it extended through 2001. And why we chose these 12 years was basically to avoid any sort of reverse causality, which basically means that we excluded any of the new cases of Parkinson's that developed within these 12 years. And that was basically to, again, exclude the fact that if somebody with subacute Parkinson's disease possibly contributed to the low physical activity versus is it the low physical activity contributing to the development of the disease. So just to exclude that, we looked to 12 years from the baseline. And we also excluded men with prevalent disease at baseline, those who died before the follow-up began, those with missing physical activity index, and those who did not meet the criteria for the lowest tile. So our ultimate analytical sample was about 5,317 men. And for the purpose of analysis, we did divide the subjects into PAI quartiles, so 4 quartiles. And for that, Max will go into the details and he'd be able to explain a little more.
All right. Hey, everyone. This is Max. I'm also one of the first-year geriatric fellows. Thank you so much, Dr. Peter, for talking about the background as well as the method. I'll be discussing mostly about the results as well as the conclusion. So this is the results slide. And then as you can see, we do have this age-adjusted incidence of Parkinson's disease by PAI quartile, which is depicted in this bar graph. How we got this PAI quartile was actually extrapolated from the 5 different activity levels, and then they were further classified into these different PAI quartiles, 1 being the lowest physical activity quartile, and then 4 being the highest physical activity quartile. And then what we found was that incidence of Parkinson's disease was seen in 118 men from the sample size of 5,370. And one clear pattern that we can see is that as the lowest PAI quartile moving towards the right to the highest PAI quartile, the PD incidence actually decreased with an average time from baseline to diagnosis of 23.8 years. And then with age-adjusted incidence of Parkinson's disease per 10,000 persons, moving from the lowest PAI quartile to the highest, respectively, was 18.4, 14.7, 10.5, as well as 9.1. And then what was significant was that the p-value for trend was significant at 0.012. Next slide, please. And then this was also our results with the multivariate Cox regression model. We used quartile 4 as the reference point. Again, quartile 4 was the highest level of physical activity index. And then highlighted in the yellow at the very bottom was comparison between quartile 1 versus quartile 4. Again, quartile 1 was the least PAI, or the physical activity index. And what we found was that there was significance in the p-value, as well as an increase in relative risk of developing Parkinson's disease, nearly doubled. But what's noted is that if you take a look at the comparisons between quartile 2 as well as quartile 3, there's also increase in the relative risk. However, those weren't significant given that the p-value was greater than 0.05. Again, all these results were adjusted for age, tricep skin fold thickness, pack years of smoking, intake of total daily kilocalories, fat, as well as coffee. Next slide, please. Yeah, so in conclusion, from our findings, there is a suggestive inverse relationship between physical activity index as well as incidence of Parkinson's disease in Japanese American men. And from these findings, what we can extrapolate is that these findings can lead to trials of physical exercise as a potential disease-modifying therapy for development of Parkinson's disease. Thank you. And I think moving on, we're going to be moving towards the QI projects with Dr. Calais as well as Dr. Aguilar.
Thank you. Thanks, Max. Are we able to see that? Okay. Loading. Okay, perfect. Well, thank you so much for giving us the opportunity to present during this grand rounds. The quality improvement project that I'll be presenting on is the standardization of advanced care planning documentation in the electronic health record. This project was a product of collaboration between the Geriatric faculty, Queen's Health System, as well as our Geriatric fellows. So a little bit of background for this project. Advanced care planning is a key component of geriatrics, helping to reduce healthcare costs and prevent unwanted interventions, to honor the autonomy of our patients, to support families as well. A significant barrier that we see for advanced care planning is actually difficulty in locating ACP documents within the EHR. So this quality improvement project aimed to improve the consistency and accessibility of ACP documentation in the EHR system. So how did we do this? For our methods, we had 24 physicians, 16 nurse practitioners who were participants from this academic geriatrics practice. The first phase was our pre-survey phase, in which we conducted a needs assessment, identifying challenges in finding and placing ACP documents in the EHR. The second phase was our intervention. So each service line developed and implemented a standardized process map for placing ACP documents into the Epic storyboard. And for phase 3, the post-survey, this is where we evaluated the impact of the intervention of the new process on ACP documentation accessibility. So for our results, survey participation was very, very high. 38 providers completed the initial survey, and then 40 completed the follow-up survey. These were identified as the top barriers to ACP documentation. Number one was that documents were stored in other systems, pretty common thing that we come across. Number two was a lack of time. And number three was unclear documentation process. So after phase 2 with our standardization, these were the post-intervention results. So there was significant improvement in self-rated skills for finding ACP documents in Epic. And then there was also significant improvement in skills for placing ACP documents into the Epic storyboard, both of which were significant p-value less than 0.0001. Conclusions that were drawn from this quality improvement project, that a standardized ACP process can improve efficacy and continuity of care in the geriatric practice. Based on the success, the process may be expanded to other subspecialty and primary care practices within the Queen's health systems. Right. Mahalo for listening. And I believe Pedro will take us home with our last project.
Perfect. Thank you, Kaimana, and I appreciate everyone for hanging on. Want to present our final project, which is a kind of a follow-up of Kaimana's presentation, but we looked at how advanced care planning promotes patient goal concordant care in our practice. And again, same affiliations, collaboration between UH, Queens, and JAPSON. So, like Kaimana mentioned, advanced care planning is an integral part of what we do in geriatrics, and it increases the chance that we align patient values to the treatment that they received at end of life. It can reduce costs by reducing unwanted care and improve palliative care. So the objective of this study was to conduct an assessment to see how our practice was doing in regards to goal concordant care. So 24 physicians and 16 nurse practitioners from our practice reviewed 3 charts of patients who had expired in the past year and determined whether end-of-life care was concordant with the documented wishes. So a total of 120 charts were reviewed by 40 providers from 4 different service lines. So clinic were 5 providers, home-based primary care was 12 providers, inpatient was 5 providers, and the majority of our practice is from post-acute long-term care, which were 18 providers. On average, our patient's age was 87 years old, ranging from 52 to 108-year-old. They were equal male and female. From availability of advanced healthcare planning documents, pulse forms were available in 86.7% of our patients. Of the 16 patients without a pulse, 15 patients did have advanced healthcare directives, and only 1 patient had no pulse or advanced healthcare directives on file. What did the poll say from the majority of our patients? 96% of our patients chose not to pursue CPR. 60% wanted selective treatment, and 35% wanted comfort care approach. Only 5% chose to receive full treatment options. And the majority, 81%, chose not to pursue artificial nutrition. We also reviewed where they expired. The majority of our patients, 41.7%, expired in the nursing home. That is likely due to the majority of our physicians practicing in long-term care settings. Otherwise, it was pretty equal between hospital, care homes, and at home with 18.3%. The providers assessed that 76.6 definitely had goal concordant care with what was expressed in their chart with what ended up happening. 16% had partial goal concordant care, and there was 5.8% that we were unable to determine, and only one patient who did not receive goal concordant care. So in conclusion, in our geriatrics practice, over 93% of our patients received at least partial goal concordant care at the end of life. And this highlights the importance of good goals of care discussion and ongoing goals of care discussions. Because each patient's journey at the end of life is completely unique and challenging, of course, directed and frequent goals of care discussions can identify what matters most to the patient and can align the patient's values and wishes, and that's what we strive for. Education and goals of care discussions with both patients and families can lead to improved quality of care at the end of life. And I want to thank everyone for your attention, and I want to open up for questions to my presentation, any of the other presentations.
Thank you, Pedro. Thank you to all the fellows for wonderful presentations. You all did a super job. Thank you very much. Before we open up for questions, I just want to give a couple of acknowledgements. First is to the Honolulu Heart Program staff, many of whom have been with us actually for decades and do such a wonderful job gathering these amazing data for us, and to the Kokini administration for allowing our trainees very generously to use these data for many, many projects over many years. So that's the first acknowledgement. And then the second one is to our Queen's colleagues. These QI projects were done as a team with many people, including nurse practitioners and physicians involved. All of the QUMG physicians and NPs participated, but there were some who were part of the planning. I noticed Jake here. I don't notice any of the other planners here, but again, thank you to all of them for helping us with QI over many years. Now we'll open it up for questions. If anybody wants to, you can just unmute yourself to ask questions if you like.
I have a question. Hi, my name is Gabriel Wishak. I'm with the palliative care team. Hi, everyone. So Pedro, I saw you were looking at the whether somebody received what they thought they might want on a previous document. And I'm wondering, what do we think is a good percentage there? Should we be at 100% where we're completely goal concordant, or is something less than that both acceptable and preferable? And what are your thoughts about that?
Thank you for the excellent question, Dr. Wishak. I agree with you. I think it should be 100% of what the care that we deliver should be aligned with the patient's values. The only plug I would say is that, patients are allowed to change their minds and their decisions, right, about the care they receive. And, at end of life, things are dynamic. So we did not account for last minute changes in their wishes and kind of reviewed those documents. So I would say that it may be possible that some patients change their decisions to pursue more aggressive care at the end of life. And I think the most important thing is kind of just encouraging physicians and practicing physicians to have those conversations and kind of reassess all of this frequently.
Thank you, Pedro. Any other questions for any of the projects?
I have a question. So now that you're all experienced at doing research projects and QI projects and root cause analyses, now that healthcare organizations are asking many of our practitioners or anyone in their systems to really help with QI, someone interested in doing a QI project or study, is there any piece of advice that you would give to our faculty considering starting a project? From your 1 or 2 years of experience now, something that you shared that you learned or found that you really enjoy or piece of advice?
Any of the
I have something. Yeah, just based on what, like, I think I talked about this with like some of you guys already, but based on like when I presented the copy at AGS, most people were interested in how I was able to gather the data. So I think if I were to kind of pursue like quality improvement in terms of like surveys, there needs to be some incentive or to make or to incentivize people to kind of complete the QI project because the data is so valuable. And while it may seem like, oh yes, like 98% is great, that's a good job, but it's such valuable data to have objectively that, and I wish people would kind of have more time to do this. So there has to be some type of incentive or something that makes people want to complete their surveys on time. So I think that's something I took away from this is that like, yeah.
And I can tell you, Queens did have an incentive to do it, but despite that, I had to do a lot of nagging and follow-up. A lot.
Yeah, exactly. So it's like if we could find like some way, if there's like an easier way than surveys to like get data, like maybe through the EHR or something like that, that would be like an amazing way to kind of show this like data that we have. But right now, I think for surveys, like it's showing me that like there has to be something else I have to do to get people to do this. So yeah.
Yeah, so can I make a comment? Is that now there is an incentive, right, for hospitals to actually be able to document that they're doing advanced healthcare planning because they now, as of January, right, the CMS is requiring age-friendly health systems certification. And I think that
I don't think they're requiring certification, Aida, but
no,
they're
no,
requiring that you
attestation, sorry.
demonstrate, yeah, you
I'm sorry,
demonstrate.
attestation, not
Right.
certification, attestation. But so that for now, and then I think later on they may, make it, well, it is kind of required. But I think that, just even beginning with placing advanced care planning documents into the EHR is really, something that now we've demonstrated we could do it. We know how to do it. We know how to follow it, monitor it. And if we can really work with the health system, that's kind of step one. Teaching them how to have the conversations is another one. But I think that, I mean, it's not, yeah, it's not perfect, as Dr. Wishik said. We're not 100%, but I bet if we look at other service lines, non-geriatric service lines, yeah, the rates are probably going to be lower and also lower concordance just because documents aren't in the EHR.
I can add a follow-up comment to that, but I would say that, there is a gap between or a barrier kind of between like the clinicians and the software tech people, right? And we always, we think it's kind of like how magic happened, but I wish it would be easier for us to pull data from the EMR, data that is relevant to the quality, what we consider as clinicians as quality care, right? So in this case, one of the big themes about this was, how can we pull out easily data that just tells us how many of our patients per provider have ACP documents on file, right? So I think kind of in the future, it would be great to have more of a direct connection between, EHR, Epic, or tech people at Queens to be able to get those, data points easier.
True. No one wants to do tedious chart review.
Any other questions, anyone, or comments? Okay, give another minute for people to give their comments or questions. And then, John, if you could put the evaluation link in the chat, that would be great. Just a reminder to everyone that to get CMEs, you do have to do an evaluation. Wanted to again congratulate our fellows for a wonderful job with their projects throughout this year. Just to let everybody know, they've presented at 3 local conferences and at 1 national conference. So they took turns leading the presentations at different conferences, but we had 3 projects presented at the Hawaii Academy of Family Physicians Conference, 4 at the Hawaii ACP, 4 at the Jabson Biomedical Sciences Symposium, and 4 at the American Geriatric Society National Conference. So they've certainly made very good use of these 4 abstracts. Congratulations to all of you again. If anybody has any questions, ask them now. And if nobody has questions or comments, we'll thank you all and hope to see you next month.
Thank
Yeah.
you.
Yeah.
Thank you, everybody.
Congratulations again, fellows.
Thank you, Dr. Masaki, for all your help.